All right, folks, here we are with the two panelists, debaters, whatever you want to call them. The problem is they're two cardiologists. I mean, so what do they know about drug prices? Absolutely a whole lot of nothing. Because your drug prices, we put them to shame, Anish. So let's do a quick round of intros a little bit. And just as part of your intro, in a serious note, like none of the three of us are policy makers, like but we're interested in policy and healthcare policy and so on. Maybe a bit of a reason why this is of interest to you, whether as a clinician, as a citizen, wherever you are. We'll start with you, Andrew, and then we'll go to Anish.
Yeah, hi. Andrew Foy here. I'm a general cardiologist. Um, and I've been just basically interested in the topic of, health economics, medical financing, for quite some time. I sort of took an interest in Austrian economics, when I was in medical school, and it sort of informed the way that I think about a lot of things in medicine. Um, And, I've also sort of blended it with some of my research interests over the years, and I have actually published some on healthcare cost growth, and sort of I maybe call them dislocations within the system. Um, and so, I mean, I have thought about this quite a bit. I've written about it some. It's certainly not, in my purview as a general cardiologist, but of course, these issues come up, whenever you're seeing any patient. And things like, costs of medical care are baked into what we do. And I think because of my interest in economics, I've never really, I've um, I think a lot of physicians, and this isn't a bad thing, but are able to kind of go through the practice of medicine sort of on autopilot, and they just sort of do what, is sort of recommended or advised based on their specialty society guidelines. And even if they have some notion that it's all costing a lot of money, they don't really sort of, think about it on like a decision by decision basis. Because because patients are, sort of in some ways separated from the decisions that are being made. Uh, but in other ways they're not, particularly when it comes to copays, and that involves drug pricing. But so I mean, to me, I've never really been able to separate the economics from like the decision making that's involved, with what we do.
So you do factor, obviously, economics in some of the decisions that you make when it comes to caring for patients, which is really
Well, no,
important.
let me say that. I mean, I will, no. So, I mean, I don't, when I'm making decisions for patients, I, make what I believe is the best decision for that particular patient, regardless of the economics. But I think when you're sort of walking through the steps of that, you have to be mindful of it. And kind of, if you sort of anticipate it, you can see where some people could get in trouble. And I try to talk about those issues sort of before they come up, when we're talking about, maybe drugs that we're going to start and the rationale and what the cost may be. And so I I do think about it. I talk about it with patients. I would never recommend something overtly inferior than, just because it costs less. So like,
Right.
does that make sense? I
Yeah,
mean, I just
totally
but I
fine.
because,
Got it.
that I would, I think, be really not fulfilling my duty as a physician to that person if I did that. But it's just when you're kind of going through the process, it never is like out of my mind,
Okay.
if that makes sense.
Anish, about you, and you've been on the show before, but also what got you interested in some of these healthcare policy items specifically pertaining to drug prices?
I'm a general cardiologist as well, and I practice in Philadelphia. And I yeah, I had no real interest in policy at all until if anyone's listened to the prior podcast or one of the last interview we did, it was the Affordable Care Act that kind of made its rude I consider rude entrance into the practice of my, of how I practice. And it became impossible to ignore how the Affordable Care Act was affecting um, patients trying to get care from me, and also is affecting the ability of patients in general to get care from doctors because there were so many doctors that were struggling with, what the Care Act kind of put into place. So that was my intro into saying, hey, look, you can't just know about, the best way to treat heart failure. You can't, or the best way to, arguing about what dose of aspirin to use after a stent goes in. That was, of course, what I spent a lot of my time on, and what a lot of cardiologists spend a lot of their time thinking about and talking about. But for me, 2010 to 2014 really was an awakening in terms of, my God, my ability to practice medicine has so much to do with these wider health policy issues. And like Drew was saying, obviously, when you're in the room of the patient, I hope most of us are not making decisions based on some populational level. We're trying to make the best decision based on the evidence for the patient in front of us. But when you put your citizen's hat on, and of course, when you put your citizen's hat on, you're kind of informed by what you know from the practice of medicine, from being with patients, from understanding the struggles that patients have when it comes to, covering medications, covering and getting medicines, getting insurance. It becomes pretty obvious pretty quickly that you have to have some understanding of the underlying financing of healthcare. And then once you get to the underlying financing of healthcare, then it's like, okay, what's the best way to finance healthcare? And that's when you enter into, the different philosophies of like how does one approach, trying to deliver, the best healthcare to people. So not so much as an individual level, making the distinction that Drew is making as well, but more on a population level. And that's where my interest in kind of policy comes from, is that, all right, you need folks to be deeply informed. The other thing that became very obvious very quickly was that, I very much wanted to be like, I'm a practicing guy. Somebody else worry about the policy things. Let's get some smart Harvard guys with MPHs to deal with this. But it became obvious very, very quickly, when the Affordable Care Act came on, and you were looking at ground truths that the MPH class, the Master in Public Health class from Harvard, from whatever university, were completely out to lunch. And not only were they out to lunch, they had no interest in listening to people that were on the coal face, that were, trying to give them inputs. It's like, fine, let's have a conversation. You explain to me, you tell me, and they have no interest in the conversation. And they just want to say, hey, this is what is correct based on what we know. What we know ends up being, living in, a room, living in conference rooms where they're making presentations to each other about what they think healthcare is, not what what they think healthcare is, not what healthcare actually is. So that's where my interest in kind of healthcare policy comes from. By the way, I got to credit Drew. Drew and I trained in the same institution in Philadelphia, and Drew was actually my first introduction to Austrian economics. One night on call at one of the hospitals, Drew was a medical student, or no, no, sorry, he was he was an intern or something like that, and I was a fellow. And yeah, he was this kid talking about Austrian economics. I was like, what the heck is that? So much props to Drew for kind of introducing me to policy at a very early level.
So we obviously can't. That's very helpful for listeners and viewers. We're going to take one policy item for today's
Hmm.
podcast that we are going to discuss, because
Yep.
you may have some, points of agreement, I'm pretty sure, like all of us, but
Hmm.
you do diverge on whether government should negotiate drug price or not. Like literally, this podcast is about, should government be allowed to negotiate drug prices or not? Is there good, bad about this? And I think that's very timely, frankly, because as you both know, the Inflation Reduction Act was passed into law under the Biden administration, and it technically should be effective in 2026 unless something happens, blah, blah, all of these things. So my understanding, Anish, is that you believe government should not negotiate drug prices, and Drew believes that government should negotiate drug prices. So let's start with Drew here. I mean, I'm not going to take sides, but we do know that other countries in the world outside of the US, it's not unusual for governments to negotiate drug prices. So, Drew, tell viewers and listeners why this is a good idea, and then Anish is going to tell them why this is a bad idea.
Well, I guess, I would just start from what I think is one of the biggest data points, which is just the US spends, you know, when we compare ourselves to other countries, first world countries, countries in the Organization for Economic Cooperation and Development, I mean, we spend 300% more on the cost of drugs. And if you actually separate the drugs between brand name drugs and sort of unbranded generics, we spend 422% more for the same brand name drugs. And to me, I mean, that's just frankly untenable. It's way out of it's much more than the difference in our GDP per capita. And it doesn't really follow any laws of economics why it should be the case that a country with the largest aggregate demand would pay the most. There's just no economic principle to support that. Um, and if you were going to say that government, setting prices was going to cause dislocations in the market and people were going to be worse off, I would anticipate that that would mean the price, I would think, would be higher, or people's ability to get the products would be less. And there's no evidence that that's the case in these countries, that they have less access to these drugs. In my opinion, and from everything that I understand, they have equal access and they just pay less. And I mean, I there's not any sort of laws of fairness why I think that why it makes sense for that to be the case. Um,
So, I mean, that's a good intro. I mean, Anish, why is it bad for us to negotiate prices and get these drugs cheaper to people that need them?
Well, first of all, I agree. I agree with Drew that we do pay a significant amount more than we probably should for most drugs. But I think we're getting the cause of that wrong. I think the cause of it is the third party payment system that does boost the price way more than what it can be. And the reasons for that is because we have this weird way of paying for healthcare, which is this in the U.S., which compared to other things that we pay for, where we pay for things through a third party intermediary, and that third party intermediary is just not as good as you are going to be at managing your costs. So I think that's the fundamental reason. And so if we want cheaper, I want exactly what Drew wants as well. I want cheaper drugs for our patients, because our patients, there are multiple drug classes that are necessary, and we need them, and we want cheaper drugs. But I don't think you're going to get there by having the third party negotiate for you. And again, it's not that. And by the way, I don't think the metric can be how much do we pay relative to other countries. I think Drew makes somewhat of a thing to that in terms of saying, okay, what we should pay should be related to GDP per capita and stuff. But I mean, those are always like who says that is how we should decide what the price of a drug
What do you mean by third party?
should be.
Can you explain what you mean by third party?
Well, I think we are conditioned in America to saying that healthcare needs to be citizens in the United States are conditioned to saying that healthcare needs to be free. Healthcare needs to be paid for by this card that I have. Healthcare needs to be paid for by this program that I control. Healthcare cannot be something that I go in and say, well, how much is the cash price for this? And have that be a system of, like it is for almost everything else. Like if you want to go buy shoes, you're not just I have a card which says I can buy shoes, and here's the card, give me shoes, right? That third party is what I think massively raises the price of drugs. I'll make it a concrete example. And the reason I oppose it is not because I think I don't want the government to negotiate lower prices than what they're paying. Is the government or payers, payers, and in this case, the ultimate payer is the patient. Are they getting hosed by the current system? Absolutely. I think we need lower costs, but the way to get lower costs is not for the government to then step in and then try to negotiate for them. I think the best way of doing it, yes, you'll get some savings there, but you won't even get the savings that you think you should get. The Austrian argument would be, hey, I think the Austrian economist argument would be, if you do have the government setting prices and they set prices below a certain amount, they're not going to get access. But here's the thing: I think in many ways, and then this is actually already proven by what happened with the Inflation Reduction Act, the government is setting prices that are way too high. So take Eliquis. Eliquis is a common anticoagulant for one of the most common diagnoses that we make in overweight America, where most people have sleep apnea and have high blood pressure, atrial fibrillation, where that's treated with a blood thinner. Well, two of those blood thinners are on still on patent. One of them is Eliquis. Eliquis has the biggest market share. That price that's negotiated by Medicare was $235 per month. All right, and and everyone is like, oh my God, look at the savings we're getting with $235
Well,
a
what
month.
was it?
We were
But what was
initially
it
paying
before? What was it before
$500. It was
235?
$500. It was around $500 a
Okay,
month.
so
All right.
50%.
Approximately, yes. Yeah. But again, this is all shrouded in secrecy because we have no idea what exactly was being paid. The list price that the pharmacy folks were saying was $500 a month. What the pharmacy benefit managers versus the third parties that the payers use to try to negotiate prices, the formulary games of what's on formulary, what's not on formulary. We don't know. We don't know how far away it was from 235. We don't even know, Chadi and Drew, whether or not that number was less than 235, meaning what the ultimate negotiated price was. That being said, there was too much that was being paid, right? But just to show you, like, why $235 a month, which the government is now saying that they're going to pay, right, is a number that is way too high, is looking at the generic alternative to Eliquis, which you can use in, I would say, 80 to 90% of patients without a problem, right? The generic alternative to Eliquis, guess how much that costs? It costs $70 a month.
All right. So Drew,
So
um,
that is close to
yeah.
3 times less than what the government is negotiating for Eliquis. And what that does is, so I'll tell patients that, hey, yes, you have this program, right? The way the Inflation Reduction Act works now is that it's, Medicare negotiates this price. You have a $2,000 cap. Once you get to that $2,000 deductible that the patients pay for, then everything is free, right? The patients are so bought into this idea of like, hey, I'm just, government's negotiated a great price for me. I'm going to get to this number. And then after that, everything's free. They don't realize that everything that they're on, right, med-wise, and I've told them this, I'm like, everything that you're on, I can get you for less than $2,000 a year, less than the deductible that you're going to meet for the year,
Okay.
right? And so this is the problem of having these third parties step in.
I do want to have Drew answer this. I just have one quick comment and then Drew will go in. My comment is you gave the example about going to buy shoes. You also
Mhm.
do not know the cost of the shoes from the manufacturer that you're buying the shoes from. You
Yeah,
do
that's
not
very
know
true.
how much they paid for the shoe either. You're just willing to pay for it. Drew, go ahead.
Well, I mean, Anish said a lot. And I mean, I think it's probably important that people understand that Anish and I probably agree on much more than we disagree with. And he knows that I believe that absent third parties, that the cost of care would be lower, and that I also think that the entire delivery system would be better at the expense of there would be some people on the margins who couldn't, who basically couldn't afford it. And not to say that there wouldn't be other delivery mechanisms for those people and that they would necessarily be dying in the street, but I mean, it is a trade-off that would have to be considered, and I'm not saying that it's wrong. However, like that's not the world that we're ever going to live in. I live in the real world, which is that the public has no appetite for getting third parties out of um, paying for medical care. And, you know, we're not going to burn the whole system down. And so with, keeping that in mind, having the largest, payer negotiate better deals for us that are commensurate with what other much smaller payers are paying around the world. I mean, it's just sort of like saying, I'm not going to consider that option because it's not as good as what the ultimate, nirvana might be. And I just think that I
I'm
disagree with that
still,
perspective. So like,
but I'm not.
let me say like, well, I need to say this or I might forget. I mean, when I look at the cost, and I'll use the example of Entresto. Um, and when I look at what that costs in the UK, in France, in Germany, in all those countries, in my opinion, it's too much. Just like Anish said that apixaban is still too much. I agree with all of that. It's too much. And if, third parties weren't involved, it would be much less because the majority of people would never pay what's being paid for it now through a third party, would never pay that directly. Even the richest people in the world, I don't think would pay that cost. But the problem is then to say that because because that's too much, I wouldn't want to negotiate to that price, which is still a third to a half of what we pay. To me, that's just kind of stupid. I mean, I don't see the point in saying that because it's not the best way to do it or the optimal way to do it, that we're going to avoid it altogether because there could theoretically be a better alternative. And I think the best example of this is the fact that, Trump just signed an executive order today to add 15 more drugs to the list of the 10 that are being negotiated by Medicare because he understands that this is a bad deal that we're getting by paying this
I,
much for drugs in relation to these other
I
countries.
mean,
It's a bad deal. It's a stupid deal. There's no economic sense that it makes for us to be paying this much more than other countries when we're the biggest payer.
Anish,
It's not, but it's not
just
theoretical.
Anish, quick question, just for
Mhm.
you, and then you answer Drew, because you gave the example about the what's the drug, apixaban?
Oh, yeah, Pixaban.
Yeah. So it was 500, and the
That's the
generic
list
is,
price. Yeah.
yeah, the list price 500. Now it's down to 235. You can do generic 70. Why is, I know you could do 70, but now it's 70 versus 235 versus 70 on a 500. Why is this a bad deal?
Oh, because patients, but here, so let me, well, because patients are paying 235 per month instead of paying 80 a month, right?
But they were going to pay
And most
500.
people, what's that? No,
They were
they
going
weren't
to,
going to pay five. No, nobody was paying 500. 500 is the list price. So they're paying through some third party in terms of
I see.
PBMs. And I mean, I don't know what exactly it is they're paying.
Those,
But the
those,
point
those,
is that
but those
the point
differences
is
are
the,
not never that much from the list prices. There's laws about that. I mean, they don't
I don't know,
deviate
there's,
that much from the list
you,
prices. The
no,
discounts
that's
are
not.
what cause the are what really get them down.
Right. So
But
that's
even
what
but
we don't, it's a tightly held secret what exactly it
yes,
is that third parties are paying. So it's hard to know what exactly they're paying. But regardless, Drew, I mean, I agree with you that I'm not looking for utopia in terms of we're not going to get rid of all third party payment systems, but we don't have to eliminate any of that. I'm not saying we must tear down Medicare to get better prices. I'm not saying let's get rid of, all third party payment to do it. But right now, what I'm saying that right now you don't need it. There isn't some system you have to create. Currently, right now, there's an active market for people that pay cash for drugs, right? And what you're doing by saying we have a solution for you, you're actually, instead of running an education campaign that says that go get the alternative to Eliquis for, imagine if the government just did that. There's an alternative to Eliquis that is much cheaper, that 80% or 90% of folks can use. That by itself would be better than saying, hey, we've got a plan for you where you're getting a big time reduction. It's $235 a month, and it makes it seem like that's a big time benefit that patients are getting. And I have to explain, and not a lot of people, not a lot of cardiologists will do that, right? A lot of cardiologists don't know what the cash price is that you can get a generic, right? And patients end up paying the $235 a month and end up paying more with the current system. So I'm talking incremental change. I'm not talking about some let's get rid of all third party systems. But if you introduce a system which ends up having most people paying more than they have to, why are we doing that? Wouldn't it be a better plan, Drew, for you to stock Pradaxa in your clinic? Pennsylvania is a drug dispensing place. You can do that. For you to stock Pradaxa in your clinic, and every time a patient came in that needed a DOAC, instead of having Medicare, the government pay $235 a month for them, for your Medicare patients, instead giving them that, you're saving them even more money. So I don't see why we can't do that right now. And this is the problem when you have, so Trump expanding the list of things that you can now cover. Again, I guarantee you those prices, I mean, I went through the prices of the 10 drugs that were covered. Almost every one of those things, generic, you get more. Entresto's a good example too, right? Entresto, I mean, do you think that Entresto is significantly better than Valsartan
In
for
most
heart
circumstances,
failure?
no, I don't.
And Valsartan is $4 a month.
I know that. That's why I
Right.
said that in these other
So
countries, they're paying too much
no,
for
no.
it.
Right,
However,
right.
you have
Yeah.
to acknowledge the fact that there's a lot of cardiologists that think if they're going to be good doctors to their patients,
Mm.
they're obligated to prescribe Entresto because it's actually recommended per the guidelines
Right.
above and beyond a
I'm
max
Googling
dose of an ACE or
Entresto.
an ARB.
Okay.
So I mean, there, you know, I
Well,
when
why not fight the
when
good
I
fight?
it's in fact when I
Hmm.
have patients and we're talking about starting Entresto, I mean
Hmm.
we have a program in our EMR. I can see what their out of pocket costs are going to be for Entresto. And I use that information, I present it to them. And if people say, I'm not happy with that, then I talk about what their alternatives are, and I don't lose any sleep over it. What I can't do though is basically right from the get-go say, hey, this drug's a lot cheaper and I would just take this if I were you. I mean,
Would you
What I'm
say?
trying,
I mean,
you
but
have to
guys,
be
mhm.
very careful about
but
that.
what I'm trying to understand still, I'm trying to understand why negotiating prices is bad
Well,
versus
because I'm saying,
versus is good, because I think
I
we
don't
have to
know.
understand why is it bad to negotiate versus it's good to negotiate. Anish, tell me why it's
well,
bad.
I think I think I'm giving you a concrete example right now that exists real world, not a utopic thing that explains why if you set the price of a drug at a certain amount, right, you
Mhm.
are the ultimate payer is getting hosed by a significant margin. Meaning there's a drug that costs one third the price, but because they don't know about it, because their cardiologist doesn't tell them about it, there's no public education program about it. They're getting hosed, and not just they're getting hosed, Medicare is getting hosed, right? So the problem with price setting is that with price setting by some central planner, as you know, Drew taught me very long ago, is that you're gonna set the price of the drug wrong. And that's the issue right now. The other of course problem is that maybe the price gets set, maybe the price gets set for something to be too low, and you have a bunch of people that exit the market because drug manufacturers exit the market because they feel that they can't make anything in this thing. I think the harder question here is not the vast the drugs that have very large markets. I think in those circumstances, for the majority of things, 90% of things, we have alternatives that are generic, and we have a working market right now that doesn't involve destroying Medicare, destroying Medicaid, or anything. The consumer can get an amazing deal on, I think, 80-90% of the drugs that we prescribe every day.
Yeah, but
The
I
hard
mean,
part.
but you
Mhm.
can say that, and you're not
Yeah.
wrong because our generic market is actually we pay less for unbranded generic drugs. I'm not disagreeing with you that market seems to be working pretty well. The problem
But it
is,
doesn't.
but the
It,
problem is that
it, mhm,
you are we pay most of the money that we pay for prescriptions through something like Medicare is for a
mhm.
small number of drugs. And then, yes, there's a lot of things that you can get that are cheaper, and we might even think they're comparable, but you have to acknowledge that there's specific reasons why those drugs are being prescribed at the level they are. And we might disagree about, their, place in the guidelines, for example, or whatnot, but clinicians can't just ignore those. And so like there, you know, there's reasons apixaban is prescribed more than Pradaxa or
Well, I think
dabigatran. I mean,
most of it is
most of it. Yes, most of it. And
most of
there
it
you
is
go.
most
Most
of it is
of it.
related to, you know, look, I saw this, and and I think this is the discussion we should have. That's a higher level discussion that we should have, and we as physicians should kind of lead this in the sense that, look, I saw when I was a fellow, right, clopidogrel when it was Plavix, right, when it was branded as Plavix, everyone was prescribing Plavix, right? And Plavix was a massive, I mean, Plavix was a fantastic drug, right? I mean, it basically changed a lot of things when it came to, you know, dual antiplatelets, stent thrombosis. I mean, it had a significant value add, right? You know, you know, so anyway, we can argue about that, but whatever. But what we won't argue about is the fact that you know the Me Too the Me Too Plavixes that came afterwards, there was not a significant value add to that. And do you know why I know this? And without even having to look at the trials, right? Um, when these Me Too's were coming out, right, and you had interventional cardiologists that were, you know, frankly, paid speakers for Plavix, right? And these new guys were coming to the market, right? I remember vividly presenting as a young whippersnapper, arrogant kid, being like, this drug, this PY212 inhibitor, that's the alternative. It has better mortality than clopidogrel, doctor so and so. Like, why aren't we using that? You know, and again, we know about all the foibles of that trial and why that trial may not be as advertised. But I didn't know that as a younger fellow. And the fascinating thing to me was the interventional cardiologists at the time would universally tell me why Plavix was superior to this new up and comer. Okay. And I was like, all right, I guess you got a point. You know, this is a once a day drug, that's a twice a day drug. If you miss it, maybe there's more stent thrombosis, etc. Right. And the thing to me that was like one of the early light bulbs, right, was the moment Plavix went generic and became clopidogrel, the moment there weren't any more reps paying, you know, paying there weren't the moment there wasn't a paid speaker bureaus, it was incredible. Suddenly, every single person who was in the hospital, it was the interventional cardiologist, was now prescribing the branded drug. I was like, wait a sec, you just told me 2 years ago that this was clearly no good, and now suddenly, like, the only thing you're prescribing is this, and now you buy that data that it was the same data from before, nothing new happened, right? It feels like, do you understand where I'm coming from, Drew? It feels like we are, instead of talking about what we should be talking about, why isn't, you know, what are the foibles in the Entresto trial? Why is it necessarily that much better than valsartan, run-in, blah blah blah? Why is it that ticagrelor and prasugrel, what are their
But in all
problems?
fairness,
Is it really a value add?
but Anish, in all
That is the
fair,
discussion that's the
okay,
discussion I think we should have, because you know, we're basically we're creating a market for these drugs as physicians, and that's the thing that we should be discussing about. By the way, and this now gets back to this, sorry for the tangent, but it is related. This gets back to the idea of what will you pay for a drug, right?
okay.
What you will pay for a drug is directly related to what your physician will say the value of the drug is to you. And I think a lot of this, you know, if we allowed the market, if we got out of the way and we said, okay, I mean, no third party is going to pay. We're not going to pay for ticagrelor. We're not going to pay for prasugrel.
Uh,
If you want to pay for it and you think the data is that good, go ahead,
I'm
recommend it
I'm
to your patient and force your patient to pay $500 a month. And it won't happen. And
I'm
because
gonna
it won't happen,
let
you
Drew
will have,
answer. I'm
yeah,
gonna let Drew answer, but I do have one comment, Anish,
yeah,
um, which is it's actually very simple. And Drew, you can go after me, but my simple thing is there is no trial that's perfect. I get that there are
yeah.
trials worse than others, hands down. Some trials are awful, some trials less awful, some trials are great, some whatever it is. But there's no trial that's perfect ever at all. However, the same kind of trial data is being used in Germany, in England, in France, and they negotiate drug prices. So I guess my contention, and Drew can go after me, is that other countries are negotiating drug prices. And I don't know. I mean, I don't think people in France are dying from heart disease or cancer because they're not getting drugs. I think they're doing pretty okay. I don't know. Drew, you can go next.
Well, no, I mean, I think that is a very good point, which is the fact that other countries with the health systems that they have in place, which might be suboptimal for a lot of reasons that we could talk about, but they are able to negotiate much lower prices, have equal access to these products as the United States, and their patients are generally doing just as well. And so again, I mean, I agree that third parties setting these prices, there's going to be, components of like lobbying involved that like get the governments to pay more than what, let's say true consumers would pay, right? There's going to be those sorts of issues where they're still setting prices that are, in my just subjective estimation, and that's truly what Austrian economics is. My subjective estimation is way more than I would actually pay for those products, right? But you know, I'm just, again, in the system that we're living in, which I don't see significantly changing anytime soon. I mean, I just feel like this is an example of like cutting off your nose to spite your face. I mean, there's no
Right.
reason we shouldn't be
Yeah.
negotiating better prices when we can.
Yeah.
And it wouldn't be, um, yeah, it would save us,
Drew,
it would save us money. That's it.
do you think the concern that Anish brought that this might lead certain
Well, let me.
manufacturers to leave the market? I think he brought this up. Maybe you can comment on that.
No, so I mean, to me, that has always been what I think is theoretically the strongest argument sort of against setting prices, which is that that basically we're paying for like the R&D costs, we're subsidizing research and drug development for the entire world. And I don't really find that to be a satisfactory argument for a lot of reasons. Um, I guess it just that to me, that's like, you know, when people engage in sort of like economic decision making, they don't generally have this theoretical thing in mind, like, well, what is the right price for the health of the company so that it continues to flourish? Like, that's just not how people engage in sort of like economic decision making. And we know that there's like a creative destruction like within a market. And so I'm just, I don't, to me, to sort of theorize setting a price to like benefit like the general well-being of the companies. And I don't like engaging in like saying that um in hyperbole about like, oh, pharma execs are going to like their mansions in Mount. Like, I mean, pharmaceutical companies are made up of people who are just living their lives and trying to do good like everybody else. It's not personal to me when I talk about like, you know, I, I I just feel like the prices that we're paying for these drugs is not economically feasible in a real market or in like an Austrian setting. And because, just when I just think of myself, I know that I know the benefits and the risks of these products, at least the ones I'm using on a regular basis, as good or better than anybody. And I can't come up with like an economic calculus in my head that would justify paying the price for these things, absent other than like, well, I'm forced to pay into my health insurance premiums. And I guess I would do it if like my insurance paid for it. Like, and that's not a very good sort of like economic calculus when you think about it. And so that's sort of where I'm coming
Yeah.
from with that.
There's so many things. So in terms of look, I haven't really. I should have taken this on earlier, but it's relatively clear to me that all because other countries can negotiate better prices does not a better health system make, right? Great. In the United Kingdom, the average cardiology salary is 70,000 pounds a year. The average nurse makes 25,000 pounds a year. Why do nurses make $100,000 a year here? Why do cardiologists make $400 to $500,000 a year. That seems a crazy amount to make for someone that's in the service industry. I mean, this is so again, this whole idea of subjective value, it can't be Drew's subjective value. It can't be Shadi's successive value. It has to be, it has to be the, when you're talking about setting rates, if the government is so good at setting rates and getting a good deal on meds, then hey, why doesn't the government set rates for all physicians? And why do we not just take out private insurers and private markets from that as well? And again, it's a pretty, I hope, Drew, you would agree that that is a definite recipe, and it's proven for scarcity. The United Kingdom and what they did in 1948 with instituting the National Health Service, where everyone wakes up one morning as an employee of the state, where now the salary is set by the state. That's led to a certain system in the United Kingdom. I don't know that that's clearly not how we want to. I don't think. I mean, would you agree that that's not something that we would want to? Yeah, is that not a world? Is that a world that we want to live in? Is that the best thing for the consumer?
I think when it comes to setting drug prices for like what Medicare is going to pay,
Mm-hmm.
I mean that's a different question, really. I mean, I don't, again,
You're talking about government price setting, and you can't really negotiate with the government, right? We're talking about government
but the
setting prices for
government,
certain things. Why can't they set prices for other things too?
but the government is already paying, directly or indirectly. They're already paying, and we have governments all over the developed world that are paying much less.
But
So
the
like,
government's other places.
and they're not dealing with scarcity, right?
Well, I mean, but so why is it that government, when it set drug prices, it wouldn't ultimately lead to scarcity, but government, when it leads to setting labor service prices, it does lead to scarcity? Why is that the case?
Uh, I think, you know, that probably could be flushed out, but I guess we just have to talk about, the systems, how these systems are set up. And I just don't, like the government, we're already paying. We're paying collectively for it. Why are we collectively paying more in the United States than in these other countries?
We pay,
That,
they
that's
pay more.
not that's not how
Mhm.
economics work.
We pay more for plumbers. We pay more for electricians. We pay
Yes,
more
and
for
it
every single
and
thing.
yes, and
So why is that the case?
that's why I talked about that's what you would look at, like something like GDP per capita. You look at, the differences, and you say,
Yeah.
well, this is, it's a commodity, but there's also mm,
We're always going to
I
pay
mean,
more, but the
there's
question is how much more are we going to pay? And so
we're,
that's where I'm getting at. I think the
we're
most
not
efficient way to do
well,
it
we're
is to get
not
to, yeah.
that's not necessarily true. I mean,
Hmm.
when you have sort of um a large amount of purchasing power, you should have purchasing power parity. That's also kind of a law of economics. And there's again, I mean, these are sort of like hard economic principles. There's no reason that we're paying more for the same drugs. We
The
should
reason
be
is,
paying
yeah,
less.
the reason is the third party payment system. That's what I'm saying. That's where we disagree, I guess. I
But
guess
we
you're
all
saying,
have
So
but we
Anish,
all have third-party payment
third party is
systems.
PBMs or payers? I'm just
yeah.
confused when you
So
say
third
third
party. So
party.
the moment you have prescription drug plans that are paying, right, and the moment that I think boosts the cost of things massively.
But
So
PBMs are
so
different than payers.
yeah,
PBMs,
yeah, yeah, yeah. So the payers so the prescription drug plans go to the PBMs, which then negotiate prices about what should be paid. Instead, the cheapest thing to do if you want Gleevec is to go to a pharmacy that does not take insurance and pay for it directly. Cost Plus Drugs, which is Mark Cuban's PBM pharmacy, is nothing but a PBM, except all they do is say, we're very transparent. We're only going to increase. We take the wholesale price and we add 6%. Of course, we don't know what the wholesale price is, so Mark is saying what the acquisition price is. That's based on a survey. We don't know what the actual thing is. So Mark may be getting more than that 6%, which is fine. But the point is, he's more transparent about what the price is than everyone else. So look, I think the market is providing lots of solutions, lots of things, even chemo, even Gleevec. So we should let the market do its thing without breaking Medicare, without breaking Medicaid,
I mean,
and we're gonna get much cheaper
so
prices that
here's
way. And what Trump
here's
is doing, I think, is a mistake.
Here's my I'm going to put my citizen's opinion here, not the physician or anything, but the issue with healthcare, Joe, in general, and by the way, just for the record, I'm not advocating for I'm not advocating for a single payer system, although we do have that
Mm,
with Medicare, but I can argue both sides. But what my point is that the only thing with the free
mm,
market in healthcare,
mm,
maybe, and I wonder what you guys think, is there are many people's lives depend on certain medications. I mean, you could live without getting like brand new, you can go and get cheaper shoes than the designer shoes and you'll still be fine. You could live in a smaller apartment versus a mansion. You can eat a burger versus steak, but you really do need sometimes these drugs to survive. I mean, there are so many examples cardiac wise, diabetes, cancer, and so on. So help me understand, how do you really take the free market concept and apply it to healthcare that people's lives depend on?
Yeah, no, I think I think that I believe we have a moral justification to deliver healthcare to everyone. How one goes about that is, I think, where the argument lies, and I think the problem is, I used to believe that government directly delivering healthcare just as a naive individual was the way to do it. But unfortunately, it seems that the government is relatively incompetent. If you want DMV style incompetence, where every morning at 7:30 I see, like, a line out the DMV on the street, then sure, have the government run things. But it's a much better approach to do what the government has done, is create orphan disease programs and fund diseases which don't have a market. So I'm a supporter. Look, it's healthcare. I think there's good arguments to be made, and I think certainly I'm a pragmatist as well. And despite the fact that I believe that there is a tremendous amount that we think the private markets would not be able to do right now, because we live in this world where everything is provided, and like we're scared to do that. And you just rewind to the 1950s. I mean, the 1950s is when blue babies were being born, and Johns Hopkins surgeons were operating on kids. The 1960s, before Medicare, was when organ transplant started. So it's not like you can't have any innovation unless you have Medicare, unless you have some third party system. Okay, so my strong belief is that even if we did not have much of the third party system that we had now, we would still have a lot of innovation. We would still have demand. We would still have need. We're a rich country. There are other rich countries that would drive demand. But that
Drew,
being said, nobody's ready for returning to the 1950s in terms of financing of healthcare. But I still think an incremental approach is what one needs to do, where one takes out and tries to insulate the larger market from the smaller part of the population that is super high cost, the organ transplants, the pulmonary hypertension drugs, the newfangled chemo that you guys, CAR T,
Drew,
these like super high cost things, right? And so I think the way to approach it in a pragmatist world, like I think I am, would be to insulate those folks and directly subsidize that, right? But then leave the rest of the market, just like leave the rest of the market alone, and try not to touch it when it comes to financing, because the rest, 90% of people are going to be fine without any third party payment system, are going to do better. Instead of paying these stupid premiums that they pay, just hold on to your premium that you pay per month and just directly pay for the drugs. And then if you have some terrible situation that happens, some, life-changing catastrophic event that happens that needs a drug that's like, I don't know, whatever, $500,000 a year or something like that, then have a state government financed option that will pay for that. So I think that's the incremental approach that I would favor. This approach of like taking insulin and capping the cost of insulin is ridiculous. I mean, before we had before we had any government taking care of insulin thing, you had insulin that you could get a month's supply of insulin for $40 a month from Walmart. The only reason I take care of tons of patients with insulin with diabetics who don't have health insurance, okay? And I'm telling you right now, the barrier to taking care of those patients is not the fact that they don't have insurance. It's not that the fact that they can't pay $30 a month or $40 a month. The barriers are socioeconomic, are related to their social situation, their ability to come to follow. I mean, there's a bunch of social factors that I don't care what the price of insulin is, whether it be $5 or $10. These folks are not going to have their insulin well managed, and they're not having problems because of their inability to access insulin. There may be one case that the media is going to go nuts about in terms of somebody who wasn't able to get insulin and a proper thing, and there's some tragic event that happens. But as somebody who takes care of uninsured patients who are insulin dependent diabetics and has done so for a long time at this point, the barrier is not the cost of insulin and has never been the cost of insulin.
So Drew, was Anish able to convince you?
I'm not sure what he's trying to convince me of. I mean, I
He's trying to tell you government should not negotiate drug prices. It's a free market.
I mean I don't, yeah, I mean,
I'm saying you're going to get a better
it's
price.
hard,
The
it's hard
patient's
for
going to
me,
get a
it's
better
hard,
price on their own.
it's hard for me to even understand what, you know, like it's not a free market now in every single way. It's not a free market. So
Drew, how do I take
why
care of
are you
uninsured
opposed
patients
to
who?
having the
But
largest buyer with the most purchasing power in the world not negotiate better prices for itself?
because that brainwashes people into thinking that the government's going to get a better price for you than you can get for yourself. So they go get $210 a month apixaban instead of paying $80 a month, and that's with a $2,000 deductible. It's not like somebody else is paying that $210 a month, Drew.
I mean,
Instead of paying $85 a month,
so I
they're
guess you
going, and it's
just,
the same thing with insulin.
but you whitewash the fact. I mean, okay, you keep using your apixaban and
I could use
dabigatran
that example.
argument. I mean, what would they have done 5 years ago when dabigatran wasn't a generic? Right? What, and
Yeah,
that, how are you going
right.
to be arguing? Are you going to be arguing that, well, they should have done Coumadin? And
Okay.
look,
So
I'm
then,
not gonna
so
I'm
if the,
not gonna even say that like that's a ridiculous argument. But my point is, we're not doing that. We have a bunch of people that are using these drugs for one reason or the other. And like we have our government who's just stupidly paying 2, 3 times more than other governments. That's just stupid. There's no benefit, that nobody's deriving a benefit from that.
Well, again, I think you would get a lower payment. They wouldn't have to pay that if they didn't pay it. The government should get out of get out of paying for drugs, period. And look, so if it would make sense to me, Drew, I would agree with you if the government chose a list of drugs that there was no generic equivalents to. They didn't do that. Guess why they didn't do that? Because they're not that good at it, and no central planner. Maybe you and I would be able to do it and make a list that we could negotiate where there was no alternative and do it. Maybe Shadi could do
So,
it.
well,
But
let me,
that's not what the government's going to
so,
do. The moment you give it up to these central
so,
planners and bureaucrats, you get an
so,
inept, non-working, non-functioning
all
system.
right. So Anish, you tell me, these are several of the
Hmm.
meds in this executive order today.
Hmm.
What is the generic to Ozempic, Wegovy, the cancer drugs, Ibrance, and Standy? I don't even know what the hell that is. I've never heard of it. But
I
what's the generic? I mean, I don't know what it is. What is it?
So the
there is no
GLP-1.
generic to Ibrance or Extendi.
So take so that those may be good ones that for people to take a stand on. But take the GLP, just even stuff that there isn't an alternative to, right? If you say third parties must pay at some price, somebody is getting hosed. Take the GLP-1s. Look what's happened to the GLP-1s in terms of the price. Okay, the GLP-1s, right, started out with a list price, the cash price with no insurance of $1,200 to $1,500 per month, right? And guess what the price is now? Because nobody can pay for that, and the price has now come down to, by itself without the government setting a price. The price has come down to $600 a month. Okay, and even that may be too much. But my point is that the moment you get involved with saying we are going to set a price, most of the time, because of the influences that big pharma, big hospitals, etc., have on price settings, it's not actually even the Austrian argument about the price being set too low by the government. The price is getting set too high, and you're still going to have a massive amount of money that's being generated by these folks. By the way, the other way to go after the GLP-1 class or these classes of medicine that are branded and stuff is to look at the patents, right, and look at how long the patents are, and to look at what these companies do to kind of keep extending the patent, right? So I think there's better ways. I'm not to get to lower prices other than the government sitting there and setting the price. And I'm making a strong argument, I think, for pointing out on various different things where the government is getting hosed because they're still setting the price way too high. So, you know,
But
um,
I don't think you're making a better argument because the government's still paying the too high price. It's just paying less of a too high price.
Drew, the
I
Inflation
mean,
Reduction Act is a
the
perfect the
government is
inflation.
paying.
Mhm. The Inflation Reduction Act is a perfect example of where they say they're going to save money and they're not going to save money. All
Well,
right,
we
they
don't
say they're
know.
going to
We
save
don't. We
200.
don't know. We don't know.
We know. We already know.
How do
They
we
say they're going to
know?
save 230. Well, because of every history of any program that says they're going to save money. They say they're going to save $238 billion over a decade. You know why they say that? They say it's from a 15%. And again, this is the other problem with supporting these bills. You're not just supporting a list of 10 drugs that they're negotiating. It's always packaged together with a bunch of other things, right? What are the things that they're packaged together? A 15.
I'm not supporting the Inflation Reduction Act.
I,
I am supporting
right.
the executive order signed today to add 15 new drugs to the list.
Well, my
But the Inflation Reduction Act did have 10 drugs. I mean, the difference between you guys, and I don't know if we're going to resolve this because we're at the top of the hour, but basically, whether it is 10 drugs, 15, 25, or 30, there's a fundamental difference between the government being able to negotiate drug prices versus the government not being able to negotiate drug prices and let the market dictate what the consumer, the seller, and the buyer are willing to pay and sell.
But it's not a market if the government's going to pay for it anyway.
No, and I
It's the
agree.
worst of all things if they're going to pay for it anyway and not set a price.
I agree. What I was trying to tell Anish,
That's the
that's when he
worst.
got
That's
the
the worst
example of
combination of all.
what he was saying about the generic. I was saying, I mean, the government was going to pay anyway, or the consumer is going to pay 500 versus 70. These are the examples. Now it's 235 versus 70, or whatever it is.
I think the government would have saved a lot more money if they weren't paying for if they didn't have a list of 10 drugs that they were paying for. So I'd be okay with pick. I don't know. Is there really no alternative to Ibrance? What is Ibrance?
Ibrance is a chemotherapy
No
that is
idea.
used for breast cancer.
Really?
There
Different
are, there,
drugs
no,
out there
no,
for
there are
come
Me
on.
Too and there is Me Too and Me Three for Ibrance. Yes.
Is that the generic? What's the generic for
I don't think
Ibrance?
there's generic. I have to look it up, but I don't think there's a generic to it.
All right. Anyway, so
But there is a
I
Me
think
Too,
look,
Me Three to it. Yeah.
you want to find some drugs that some specific drugs and I said that earlier, right? Like look, if there are some, the orphan drug programs, things that there's nothing else for that are massive costs and stuff, and the government wants to step in and subsidize those directly. Again, Friedman would say that the way to subsidize, to subsidize this is not to set up a program that then pays for it, is to give patients the money and then have the patients pay for it. But whatever, if you don't want to do that, fine. Pick a list of things that
I
there's
take
no
it back.
generics.
I
Pick
take
a
it
list of
back. There is
things.
a generic Ibrance. Hold on. I just Googled it. Hold on.
Yeah, yeah, right.
I
My
think
wife's
there
an
is a
oncologist,
generic.
remember? I thought she told me there was a generic Ibrance.
Yeah, there's a generic Ibrance. I sorry.
Anyway, so good. So another fail for the government where, you could get something for much cheaper. What is the generic Ibrance?
It looks like is there no, 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 sorry. Hold on. Listeners, viewers, sorry. I just Googled, is there generic version? No, there is currently no therapeutically equivalent version of Ibrance in the United States. So I'm actually, I was correct when I said that in the beginning.
Okay.
But
There's no HER2
there is
negative.
a Me Too and Me Three. There's actually two other drugs that have
Okay.
the same mechanism of action. They're all patented. But
They're all patented.
okay,
Okay.
well,
Okay, fine.
we
So
need to wrap up a
yeah.
little bit. So we need to come to conclusions on both sides. Like any, I think I love the fact that we have no agreement,
I mean,
but
I agreed. No, I mean, I didn't. I'm not. I don't think I'm disagreeing really with Drew. I'm saying I'm agreeing that look, as an interim, as a pragmatist, I would be okay with find a bunch of make sure you find a bunch of drugs that there is no alternative to, and for folks that are at some income level or whatever, you provide some type of payment. I mean, the 340B program, Shadi,
yeah,
that's what the intent was, right? The 340B program, it specifically sets a price for
yeah.
folks that are supposed to be indigent. Now we know the 340 program is massively abused by Beverly Hills, Cedars-Sinai, and all that. Again, showing you why setting these programs up ultimately leads to abuse. Another reason why we shouldn't have those programs at all. But if you want to set up a program which specifically pays and sets a lower price for folks that are below a certain income level, if there's no generic, fine. Like go ahead. But I think it's inane and dumb and a waste of taxpayer dollars to pay
All right.
$210 for
Well,
Eliquis when
let
you can pay $75. So
let's leave people
that's
with
my
final
two cents.
final thoughts from both of you, and try to keep it maybe as concise as possible. Maybe final thoughts, Drew. Final thoughts. I don't think either of you convince each other with the opposing view, but maybe final thoughts. We'll let the audience dictate what's the right thing.
I don't, I mean, it's hard for me to boil this down into a couple final thoughts other than just I uh I can't. I mean, I think here's a little game that like I think Anish is kind of playing here, right? Which is we don't want the government to set a price, but we know the government is paying for the health care anyway, and we don't want the government to like get between the decisions between patients and their doctors. So we want the government to basically pay, but we don't want them to be involved in the decision. And, I just they're already paying. We're all collectively paying directly and indirectly. And there's just no good reason why
I
we should
don't
be paying twice as much. There's no
I
economic argument to support that when these other, I'm not saying the other countries have better healthcare systems, but they're doing better in this regard because, if you're not going to have a free market, you can't have it be sort of like half and half, which is just we'll pay for anything and we'll do it with, everybody else's money. And we'll also just pay the whatever price, the manufacturer sets. Like you can't that's the worst sort of economics of all. I just
All right.
don't
Final
there's
thoughts
no way
from
to defend
Anish.
it.
Final thoughts from
Yeah,
Anish.
yeah, I don't know. I just think we're talking past each other a little bit in terms of I don't think we're I mean I don't want I mean it's like this binary like government pays for everything or government doesn't pay for anything. It's like yes, we have a system where Medicare pays for physician services. Do we want a system where Medicare also then pays for drugs? I think that's a bad step because I think once you do that, and certainly when you do that in this way, not with a scalpel, with this sledgehammer where you pay for everything. Medicare is like, okay, I'm going to pay for everything. I'm going to pay for amlodipine. I'm going to pay for valsartan. I'm going to pay for DOACs, which have a generic. Then the government, the taxpayer, all three of us here are going to get hosed. So I don't see any type of contradiction in my saying, okay, fine, you don't want to touch how Medicare pays for physician services and pays for hospital admissions. Okay, but can we all agree that Medicare now getting into paying for generic drugs is blindly stupid because it's going to hose the taxpayer? We're not already paying before the prescription drug plan was set up. We weren't already paying for drugs. Medicare now is paying a lot more than it was before. So
But,
let's keep it as Medicare Part
but
A, B, and C, and not let's add D.
well,
Because
but
pretty
wait,
soon we're going to add Medicare E and F, and Drew's
but
going to be being
D,
like, oh, well, we got E and F, and hey, because we got to save
but
money. It's like, no, the way to save money is not to have Medicare D, E, F,
but it,
right?
oh, but Anish, we have
No, those
Medicare
final
Part
thoughts. I
D.
got the final thought. No,
No,
what's that?
how long has Medicare D? This is not new.
George Bush is Medicare D, and it
Okay.
was wrong, and we should rewind it. If you're saying that we can't rewind
Well,
any of it, then
see that now I feel like we need a whole nother show because
Medicare
that
Part
is
D makes no
completely.
sense. Why would we have Medicare Part D where we have paid the government again? It's like Medicare
Because you
Part
can't
C.
afford drug prices.
I mean,
Yes, you can. We're getting hosed by instead of patients paying $4 a month for amlodipine, they're paying. There's this Byzantine system. Like let's not have this weird system and
All
not.
right.
I mean, so if you
Well,
want the government to pay less, let's have fewer Medicare programs.
I don't think any politician could ever run on the platform this day and age of getting rid of Medicare Part D and winning.
we're
Oh,
gonna leave it
that's
at
I
that.
mean,
We're gonna
yeah.
leave it at that because I am we can go really all night, and I know you guys
Yeah.
are on the East Coast. Well, this podcast will be airing in mid-May 2025. We have taped it mid-April 2025, and hopefully between now and then, we'll have to see what happened to these executive orders. All I know is they're going to have like about 25 to 40% tariffs on Anish. All right, folks. Thank you very much.